invite the speakers from this morning to please come at the front table. And we already have some questions which have been put up. And the first one is, Dr. Balkhy, have the results of the recently published ART trial influenced your approach? Great talk, thanks. Sam, do you want to take that on?
Thank you for that question. It hasn't actually. I think what Dr. Kieser has just shown us kind of contradicts that, and I think using double IMA, especially if the likelihood of a sternal wound infection is 0, if you don't open the sternum, then I think using 2 mammary arteries is the best thing that we can do. Teresa?
No, the ART trial is unfortunately fraught with a lot of problems. The crossover rate was like 16–70% from BEMA to SEMA, so clearly I think the surgeons were not experienced as many issues with it. And also at 5 years, you don't usually see the results of BEMA versus vein. The vein starts to go down between 5 and 7 years. Fitzgibbon coined the term 7.5-year phenomenon, but I fear that even at 10 years, I don't think there's going to be a difference.
Another question was, Dr. McGinn, if you had a robot available, would you use it for ITA harvesting?
That's a great question. I'm sitting next to the robot genius, so I got to be careful what I say. That has always been a big question, and the real answer is that there's advantages to each. The big advantage to the robot is you get to both mammaries. You get to the right and left pretty easily. The disadvantages of the robot are it does take time. Docking, what would you say, docking about a half an hour, 40 minutes?
2.5 hours. About 3 minutes.
Seriously? All right, so there's really no disadvantage to the robot. But it is expensive, and it's not readily available in most hospitals. And that's probably the big thing is in my place we have 3 robots, but they're under high demand. It would be tough for me to get it. But I would say that technically it's much easier to get to the right mammary, and number 2, ergonomically, it's phenomenal for the surgeon. You sit in a chair in the corner of the room. The way I do it is very difficult from a ergonomic perspective. So, yeah, I've done the robot a bunch of times. It's a nice technology, and obviously gives you a big advantage to harvesting the right mammary, and that's about what I would say.
I would just say that the availability of it, it's always available. It's in your hospital. Most hospitals have at least one, and you just have to fight for it and try to get it out of the urologist and the gynecologist's hands to use it. And in terms of docking, I think 3 minutes is after you've gained a lot of experience with using it. But it can be a little bit longer early on. But I think those are just little things. In my practice, the robot is part of everyday practice. 90% of my surgeries are done with the robot, whether it's intracardiac or epicardiac. And so I think it's merely an instrument, and it's getting better every day. The XI, which I kind of unfortunately don't have because it doesn't have the stabilizer, is really, really easy to dock. There's a little X marks the spot, and you just kind of bring it in, and it kind of does the same thing itself. So I think those things are in the process of getting better as we go along even.
Have you looked at the incremental cost associated with using a robot?
Well, I think there's a lot of different things that go into cost, and the way we calculate it is obviously differs from place to place. But we looked at our sternotomy patients at the University of Chicago and did a little financial comparison, and we save money. I think Fran has the biggest experience with that in terms of the number of days that the patients stay in. So it's well worth. Our intraoperative costs are clearly higher when we use the robot, but then when you factor in the fact that these patients go home on the second day, many of them go home on the first day. And if you have a hospital that has 100% occupancy rate, it really makes a difference. And that's why they continue to really be supportive of it.
We have a few more questions, but I just wanted to ask, and perhaps I can invite Dr. Bonatti to comment as well. So you were saying don't get an XI because they don't have a stabilizer, but the XI, on the other hand, as the ports, I think, are easier to use, and many, perhaps several members of the attendees and the faculty may be looking at getting a robot. What's your recommendation? Do you think that's going to be overcome? Like, I don't even know if you can buy an SI today. Can you? Johannes, do you want to comment as well? Or?
We were confronted with this question.
Let's get the mic to or ISMIC's president, Dr. Bonatti, so I think a worthwhile comment as well.
Yeah, thank you for the microphone and the question. No, we were confronted with this question when setting up the unit in Abu Dhabi, and we decided for an SI because XI, we had no stabilizer available, and that was just prohibitive. The only thing that can help is pressure from the heart surgeons community to make the company produce it for the future. I mean, overall, the XI is a beautiful system, and probably the future one, but we need those tools. At this point, I think yes, yeah.
I'll say that if you're going to use the robot for mammary harvesting and you're not intending to do a TCAP, then I think an XI would be the right choice if you're buying a new system today.
I think half the battle of doing robotic surgery is having robot time. You know, particularly in the coronary business, coronaries come up and you have to do them. And if you don't have a robot available, or you have it like the second Tuesday of the second month of the year, there's no way you're going to do it. So, you know, when I started, I was just getting it maybe once a week. And it was very difficult. And then somehow I got into twice a week. It was better, but it wasn't until I had it at least 3 times a week. But now I have it every day. I have my own robot in my own room. I operate every day. And that makes it easy. But it really is like the biggest battle is getting a robot time.
So you need a dedicated robot.
Yeah, pretty much. A dedicated cardiac robot at least.
If I could, I'd like to expand on something that Dr. Bonatti mentioned, and that is our collaboration with industry. The more we use these advanced gizmos, the more industry gets involved in advancing their cause, which is to make better and more efficacious devices. And if we, as a group of cardiac surgeons, start doing more and more minimally invasive stuff, industry will follow with the advanced technology. And I think it's important for all of us to understand that we can't do this without industry.
I absolutely agree, and Danny Becancourt wants to make a comment, but you're absolutely right, and I think we forgot to thank industry this morning, because many of the events that you've seen have been in conjunction, and often very, very strong academic collaborations, and not always directed towards money, but really towards a vision of improving care for cardiac surgery patients. And certainly the relationship that Joe and I had with Medtronic, which is disclosed, has been one of really successfully developing the mixed cabbage platform, and which goes on today. And I think you can see industry has been involved in this meeting, and we have to thank them for their vision as well. Danny, you had a comment?
I just want to comment from the perspective of a mid-cab surgeon after 10 years and then starting with a robot. The key question is, why would you not use a robot for a memory takedown? Because it is so much easier. The cost question is really important and something that we don't fully understand all the time. The laparoscopic disposables are really expensive for a lap chole, for a single site lap chole, etc. The disposable, reposable, reusable robot instruments add about $1,000 to the cost. The Medtronic stabilizer alone is an $1,800 disposable device. The CTS retractors we used to use are $1,200. So we think the robot is expensive. Actually now, the robot's already been bought. It's been paid for. It's in the hospital. You just have to fight and get the time for it. But if you have a patient who's not otherwise going to heart surgery, so now you've got a patient who's going to get a PCI or medical therapy. Now they're going to heart surgery. They're getting the hospital's getting reimbursed, contribution, profit, all this money for a surgery that wouldn't have happened, and the patient's going home in 2 days. So the profit on a mid-cap, on a single vessel bypass, is tremendous. And those Fran's shown in his experience, my experience too, and the number of patients going to heart surgery is higher for you and for the hospital. So I think it's a huge profit center. There's no question. It's an easier operation to do. It's what the patients should have, which is a mammary to LAD, and they otherwise would get a stent or some CTO or some other crazy thing. I think there's just, the cost part of it is profit. It's actually not a cost.
Thanks, Danny. We have another question for Dr. Kieser. Nice presentation. What BMI do you say is prohibitive in a female diabetic patient for BEMA?
Sorry, I should have said that it's 30, but having said that, I did operate by accident on several women that were like below 35, between 30, and they were fine. So, but 30 was the cutoff for this paper.
Great talks. What about Preop CT for all robotic patients? Sam, Fran?
Well, I think the CT localizes, you know, Balkhy uses it all the time, but when I use the chest x-ray, I'm trying to simplify the whole, everybody gets a chest x-ray when they come in the hospital, and that's, I can get away with the chest. Is CT better? It is better, but it really isn't mandatory. And, you know, it's just a matter of streamlining the coronaries. They come in, they need to be done. You start fooling around getting a CT scan and like you wait a day or two or you can't get it done for whatever reason. I just like to go with routine and get the work done.
I agree. This has been our approach with valve surgery too. You know, we're surgeons. We should be able to develop an exposure on the vast majority of patients, except someone maybe would have like a tuberculosis, pericarditis, or something like that. We should be able to develop the exposures and have an operation that gives us the exposure every single time, even a minimal invasive operation. But Sam, your thoughts?
I would say for my cases, my mitral cases, we always get a CT angio, and I think that was emphasized yesterday to look at the peripheral vasculature and understand your cannulation techniques and make sure that that's safe. In these cases, because 99.9% of them are off pump, or 99% of them, generally we have not been getting CT scans. We evaluate the chest x-ray very carefully, and as I had demonstrated, using the stabilizer to give you room inside the chest in addition to the CO2 insufflation has made it extremely helpful. So I don't really think that the CT scan adds much in terms of preoperative planning or changes our style of surgery.
Great. Our next questions, the next one is very apropos, but very ambitious. What's the optimal strategy for hybrid vascularization? I think if we tackle on this, Dr. Ramchandani is going to turn off the lights in about 5 minutes. So I think we'll pass on this one, but a great topic for next year, definitely at Re-Evolution. Why obese female and not obese, I guess, males and transgender and et cetera, and what is it, Q2? What's the new denomination? It's getting developed every month. But Dr. Kieser, why only born females?
You know, good point. I'm not sure. It could be hormonal. Our anatomy is certainly different, and to be perfectly blunt, the sun doesn't shine here very much. So, you know, I think this is partly it.
Okay, great. And I think the data supports that too, that an obese female is even much more at risk of infection than an obese male, and especially if you add COPD and other risk factors, because it becomes prohibitive. And there's ample literature on this. Dr. McGinn, you spoke of Lima LED mixed cabbage. When do you do multivessel? And I think this question is not from me, but it's from me as well.
And I'd love to hear your comments on it. My philosophy has basically been, I take whatever patients come my way and I do complete revascularizations on them. If the cardiologist requests, I'll do a hybrid with that particular case. But by and large, most of my cases are multi-vessel. If you look at the actual percentage, I do about 20% are single vessel. The bulk of them are triple bypasses. But the interesting comment I'd like to make about this is that it's amazing how many single vessel bypasses I see because I do minimally invasive surgery. They come out of the woodwork. I see patients who have totally occluded vessels. I see patients who have osteal LADs, complex bifurcation vessels that I never would have seen in a standard practice. Marc, what's your comment in multi-vessel?
Yeah, I think there's Niv wanted to comment.
Yeah, I have one comment and one quick question to Teresa. I think when we talk about cost, we all have to be very careful. You know, when we do those specific operations, the attention to details within the cabbage population, even in the same institution, is much higher because there's a dedicated surgeon. You know, in a large system like ours, when I was obsessed to outcome and so on and so forth, we got to mid-sternotomy cabbage on bypass cross-clamp, less than 10% infusion rate, 3.2 days in the hospital for elective cases, less than 1% mortality, and 0.25% mediastinitis. So I think you can get excellent outcome, but the issue of whether to do it or not could be justified in other ways, and I think all the reasons that were made are excellent. So I'm not contradicting that, but I say if we are talking about cost, we have to be careful. Teresa, for you, what do you think about this new generation of vein grafts with external conduits and external support?
I think there's several new things coming out about vein grafts. I'm not sure about the stented. I don't know if the numbers are out yet on that, but certainly the no-touch technique for harvesting of the vein graft will make a big difference. I remember Fitzgibbon, whom I worked with for 2 years, said, if I have heart surgery, I want the resident to open the chest and the surgeon to take the vein. You know, so I think it would make a big difference if the veins were harvested no-touch technique. I mean.
Interesting. The last question, I think, is also a great question for next year, perhaps, Mahesh. What strategies do each of you use for pain control? And a tremendously important question. I certainly, at my institution, we don't have this pain culture always in the back of our mind. We're kind of happy to doing a great operation and providing great care, but we're not pain-centric. And I think which will be a wonderful topic for next year at Re-Evolution. So on this, we'd like to remind you of the faculty photo, which I think is coming up. The break will be